Good morning and welcome to CQC Public Board meeting for May. We have no apologies for absence, but I am particularly pleased to be able to welcome Belinda Black to our board. Belinda joined the board on the 1st of May, and this is your first board meeting, so extremely welcome, Belinda. Lovely to see you. Also like to welcome Sariat Orlanji, who is the Vice Chair of our Carers Equality Network and is with us today. You're extremely welcome.
Thank you.
Can I check that there are no declarations of interest anybody needs to raise? Excellent. I think that then deals with the preliminaries and takes us on to the minutes of our meeting of the 21st of April. Are they a true and accurate record of everything we discussed?
Yeah.
Excellent.
Yes, thanks, Peter.
So they are approved. That's good. And there is nothing on the action log that is outstanding. Is there any other matter arising anybody wanted to raise that's not otherwise on our agenda for later? Okay, good. So Ian, can I hand over to you for the executive team report, please?
Thank you, Peter. Thank you. The report this month is sort of uncharacteristically short, and that's quite deliberate. I wanted to do a couple of things really. One, to reflect the fact that later on the agenda is our end of year performance report, and whilst we will cover off our performance as an organisation during that report, I thought it would be useful as part of the exec team report to invite each of the chief inspectors to cover off their headline reflections on risk in their sectors. And I know Chris Day is also going to talk briefly about some of his thoughts on give feedback on care in particular, and the important role that give feedback on care, which of course, as you know, is both our telephone and our digital service for receiving information and intelligence from the public. Just cover off the important role that plays in driving a lot of our activity at the moment. And so, you know, in this public board meeting, just a shameless plug to the public to make sure that they tell us about their experience of care. And obviously we live in interesting times at the moment. So we launch our new strategy on the 27th of May, which I hope will position us well to examine these sector risks and to act on the sector risks that the chief inspectors will talk about, as well as, I think, making us fit for the future as we start to look forwards towards system working, or particularly strengthening system working, as outlined in the forthcoming health and care bill. So, and I think we also need to, recognise that our performance, our strategy, and the risks that the chief inspectors will talk about have to be placed in this whole era of COVID recovery, which I think we're in at the moment. And depending on who you talk to, there's estimates of somewhere between 2 and 5 years before we recover from the aftershocks of COVID. So that's all I really wanted to say, Peter, before I hand over to Kate to kick us off on closed cultures and her reflections on her sector. Thank you.
Thanks, Ian. Thanks, Peter. So I'm going to talk about closed cultures and learning disabilities first, and then I'll pause for questions. Then I'm going to talk about care home visiting and pause, and then do the risk piece, if that's okay. So first of all, on closed cultures, so we've got refreshed guidance that's been published externally earlier this month. Next week is Autism Awareness Week, so we are launching our mandatory training for all CQC staff around learning disabilities and people with autism, and that will be rolled out through the rest of May into June. We are currently piloting our new quality of life tool when we are out, at the moment focusing our inspection activity in inpatient units. And this quality of life tool really looks at how we understand what it feels like to receive care from the person who's in receipt of it. It looks at how you can have a very beautiful care plan, but how do you understand and have assurance that that care plan is what is being delivered for those people who are receiving care. And finally, on closed cultures, board will remember that back in October, we published our report called Out of Sight, Who Cares? And in it, we called for various other organisations to take action to stop people inappropriately being placed in inpatient units a long way away from their family home, and often as a result of that getting quite poor outcomes. As a result of Out of Sight, we've taken action. So we have appointed Debbie Ivanova as our lead Deputy Chief Inspector to drive our work around regulating services for people with learning disabilities and autism. What we really need now is the other organisations who have recommendations against them, as outlined in Out of Sight, Who Cares, to make good progress on that and to update us. So we've written to those organisations asking for an update, and we will be reporting on that later in the year. So that's a bit about closed cultures. And then briefly, the work that Debbie Ivanova's leading on learning disabilities and autism. So it has kind of 3 areas of focus. The first one is making sure that we register the right services. So that's our commitment around right support, right care, right culture, that we register services that are going to deliver the best outcomes for people. It's about making sure that we transform the way we regulate services for people with learning disabilities and autism, and that we take robust action where we find poor care. And it's also looking at the pathways where people are accessing health and social care to make sure it's joined up. And through May, we've undertaken 4 inspections of inpatient services where we were concerned about the quality of care. So I'll just pause there briefly and ask if there are any questions around closed cultures and learning disabilities before I move on to care home visiting.
Any questions? No, okay. It's really, really important topic, but obviously no questions, Kate. So on we go.
Okay, thank you. So care home visiting. So board, we've talked about this on a number of occasions, and it continues to be a really important issue for care home residents, for family members, and for those providing care in care homes. So just wanted an opportunity to remind board our position on care home visiting. So throughout the pandemic, we've been absolutely clear that we expect providers to take a person-centred approach to delivering care, that they should follow government guidelines, they should listen to local advice from their directors of public health, but they should absolutely look to make visiting happen where possible. Obviously, there have been changes along with the lockdown changes for people to have access to visiting and designated carers, etc. We're in regular communication with the sector about our expectations. We have frequent conversations with the large corporate providers about how they are ensuring that visiting is happening and how they're assuring themselves about their corporate policies and how that's translating to their various care homes. We are then looking at visiting on every inspection. So every inspection has a mandatory question about visiting. We're having regular conversations with local authorities to kind of corroborate the information we're being given. And our information we get through our Give Feedback on Care has been critical in helping us understand how visiting is going. So we took a snapshot of the last 8 weeks. We've undertaken 941 inspections in care homes, and as part of each of those inspections, we've looked at visiting. In 95% of occasions, we were confident and saw evidence that visiting was happening as per government guidelines. In 5%, we needed to take some action, and that was often a conversation with the provider to ensure that they were doing what they needed to. And then finally on visiting, we are absolutely clear that we do not expect to see any blanket approaches to visiting. Even in circumstances where there is outbreaks, we would expect a provider to enable visiting to happen in circumstances such as end-of-life care for people. We are asking the public, we are asking representative bodies to tell us if they know of any homes where there's a blanket approach to visiting. And each time we've been informed about a blanket approach, we are going out and we are taking action. And that action can be conversation with the provider, physical inspection, raising a safeguarding alert, and working with local authorities. So I'll just pause there, Peter, on care home visiting.
Robert.
Thank you. I'm really encouraged, if I may say so, to hear the extent of inspections that's going on and the focus on this issue. Just 2 questions, really. When you say 95% were enabling visiting to happen, do you mean by that enabling visiting to happen satisfactorily and flexibly and on an individual basis, or just that some visiting was happening? And the second question, which is more or less not quite the same, but in terms of the blanket approach, when we talk about that, are you talking about a blanket approach not allowing visiting, or a blanket approach to the restrictions that are placed on visiting? And the reason I ask is that I know that in some places there seems to be a wide variety of requirements about PPE, screens, whether you can go outdoors, indoors, and so on. And some of that, of course, is place specific. but some of it isn't, and I appreciate the difficulties some places have, but I just wondered what our approach was to the more nuanced part of this exercise.
Thanks, Robert. So I've been talking to my inspectors and my inspection managers and my heads of inspection a lot about this over the last few months, and the kind of strong message I get back from my frontline staff is that visiting is happening, but it feels very, very different for residents and for their families. So visiting is happening, but it might involve booking a slot to visit your loved one. It might involve seeing them in a different part of the home. There might be a limitation on the time spent in visiting. So visiting is happening, but it feels incredibly different for people. And I think that's where there's sometimes a mismatch between people's perceptions about whether they're able to visit their loved one and the kind of reality. Again, you raise an important point. Every care home has a different geographical setup. So in some care homes, they can make visiting happen in a way that feels more acceptable to families. In other care homes, because of limitations around their environment, it might still be in a pod in the garden or in a communal area, etc. So when we look at it, we want to see evidence that visiting is being able to happen, that it is as flexible as possible. But we absolutely note the challenging role that particularly care home registered managers have had over the last year of that balance. And I'll talk about it in a minute when I talk about risk of physically keeping people safe, but also endeavouring to meet their well-being needs to enable them to see their families as well.
Thank you.
Thank you.
And I think, Kate, I mean, that number of inspections is really phenomenal, and I think the board would want to thank your inspectors and your teams for doing that. And of course, they're not just inspecting for visiting, important though that is. It's obviously very much a safety, infection prevention and control inspection. So really, really important, and they're just phenomenal. So thank you very much through to your teams, please.
Thank you, Peter. So if I just move on and just do a kind of look back over the last year and just provide some comments to board on risk in adult social care. So I think we've had really good visibility of risk within the sector over the last year. So 70% of social care providers have had a regulatory activity with us, and that might be one of our structured monitoring tools, or that might be a visit. And generally, the social care providers, social care workforce have done an absolutely fantastic job in these unprecedented times. So I'd like to start off, before I move into talking about risk, by noting that the majority of people have done an absolutely outstanding job over the last year. Chris might talk about this a bit more, but we've, in light of our decision early on in the pandemic about pausing routine inspections, we really wanted to see how we could do more to hear from people about their experiences of receiving care. So there's been a big push over the last year on asking people to give feedback on care through our joint campaign with Healthwatch England called Because We All Care. And as a result of that kind of national campaign, in adult social care, we've never received as much intelligence from people who receive care and their families and people who work in the sector as we have done over the last 12 months. So on average in adult social care, we get about 1,000 whistleblowing concerns a month and about 2,000 safeguarding concerns. So we get a huge amount of intelligence that comes into us. And each of these bits of information, each of these bits of intelligence helps our inspectors have a really good view of quality and risk. Where we have concerns about a service, we do a variety of things. We usually start off with picking up the phone and having a conversation with the provider. We gain additional information from other stakeholders like local authorities. We'd undertake monitoring review calls, or we'd go out and inspect, or a kind of combination of all of those. During last year, we undertook 3,553 risk-based inspections. So these were where we were going out because we were concerned about what was happening in the service. So of those 3,500 inspections, we found breaches in regulation in slightly over 1,000 locations, so 1,059 locations. And the breaches we found were similar to the breaches we used to find prior to the pandemic. So they were breaches around Regulation 12, which is about providers delivering safe care and treatment to people, and Regulation 17, which is about good governance. So we're going out to these services. We've got 25,500 providers. We're going out 3,500 inspections because we were worried to begin with. And of those 3,500 inspections, over 1,000 we found breaches in care. We then, in each of those circumstances, would use our enforcement policy. So we've got a range of powers that we would have used, from requirement notices, putting positive or restrictive conditions on a service, or removing the registration of a service. So that is a rare occurrence, but just to give board a flavour of what that's looked like over the last 12 months. In 61 locations, we closed the service down as a result of our enforcement action. So our focus is usually supportive, enabling the provider to take action to improve outcomes for people, but where people are getting unsafe care and we are not confident in that service's ability to provide safe care, we can take action and close services down. And then finally, on risk thing, before I pause and invite questions and hand back to Ian, as I've already mentioned, there's been a real focus over the last particularly 6 months on the care for people with learning disabilities and autistic people. So we had our site in October, and then we had our Glynis Murphy final review report in December. And both of those really important pieces of work told us that actually people with learning disabilities and autistic people are at higher risk when they're in an environment a long way away from their community and their family home, receiving care where there's maybe less visibility from external visiting professionals and families. So we have decided, we've made a conscious effort to prioritise our efforts on the risk we perceive for people who are in inpatient units. And as I've already mentioned, through this last month, we have been targeting our inspection activity at those poorer quality inpatient services, and we are taking action where we're finding poor care. And once those inspection reports are published, I'd be really keen to give board a bit more of an update about what we are seeing in that area. So that's a bit of a summary for me in terms of risk from my perspective, Peter.
Great, thank you, Kate. Ian, if nobody wants to ask anything, are we moving to Ted?
If we're going to move on to Ted. Thanks, Peter.
Sally's put her hand up.
Oh, sorry.
Sally first.
Yep, sorry. Thank you, Ted. Sally.
Thanks, Peter. And thank you, Kate. I'd echo what Peter said before about such an impressive long list of inspections. So thanks to you and your team. I just wanted to ask, where you found the 1,000 breaches, can you give us a sense of how serious they are? So are they minor breaches which are broadly fixed quite quickly when you point things out, or do you think they're longer term embedded problems? Because 1,000 is still quite a huge number, but if 990 of them are actually relatively minor, and once you point it out, the setting improved the care they offered, then that's very different, isn't it?
Yeah. Thank you, Sally. So we think of those 1,059 locations with breaches and the fact that we closed 61 of them. That gives you a bit of a proportional scale about with the rest of those. Either they improved quickly and we kept an eye on it, or they're still on an improvement journey and we are keeping a close eye on their progress. But of that 1,000, the fact that 61 we needed to take action to stop the service delivering care hopefully gives you a bit of a flavour of severity. Usually when issues are pointed out to providers, they are eager and quick to want to address them, because most people are in this business because they want to provide high quality, excellent care. And sometimes it's having a fresh pair of eyes come in and say, you really need to refresh your policy around infection prevention and control. This is maybe what a good practice policy looks like. That is enough for them to take the action they need to address the issue.
Thank you, that's reassuring.
Right. Now, Ted, it is your turn. Thank you.
Okay, thanks, Peter. So I just like talking about risk in the hospital sector. I just like to break it up into 3 areas, particularly. The first area is very much related to the pandemic we've just come through, and I've talked to the board before about the amazing response to the pandemic from the acute sector, and I think coming out of the second phase of the pandemic, we can be enormously pleased by what was achieved in terms of meeting the immediate acute demand of the pandemic. But of course, that has had onward effects. And first of all, you'd have heard earlier on this week that the waiting list for planned procedures is now running at record levels. Nearly 5 million people on the waiting list in England, and 400,000 of those waiting more than a year. So there's a very significant impact on patients waiting for planned procedures, and we need to focus on that now. But of course, this is in the context of services that still have reduced capacity because of precautions they're taking against infection, but also staff that have been through managing enormous pressures at the height of the pandemic, particularly the second wave of the pandemic. So when we're working with providers, and the providers are telling us that they are putting in plans to deal with this backlog of planned care, but equally we are asking them about their plans to manage their workforce and make sure their workforce get the support and respite they need in order to go on providing high standards of care. And I think it's very important as we deal with the aftermath of the pandemic that we focus on the effects on the workforce as well as that effect on patients. We've got to balance both effectively to make sure we can sustain that recovery for the protracted period that's necessary that Ian was talking about a little while ago. Another effect of the pandemic that perhaps we wouldn't have predicted is I was meeting with emergency medicine clinicians from all over England last week, and they tell me that they have seen a surge of cases attending emergency departments throughout England. And this seems to be pretty consistent across the whole country. And this was being swelled by patients attending for minor injuries and minor illnesses. And this includes children, this includes people with mental health problems, and it also includes people who are on the waiting list for planned treatment, who are coming to emergency departments because they're worried about their condition. And I think there is an exceptional pressure now on emergency departments. It's different from the pressure during the peak of the wave, the second wave. During the first wave, emergency departments were relatively quiet. During the second wave, there was a lot of serious patients presenting at emergency departments over the winter. They had a difficult winter. Now they are having a difficult summer, and this is driven by this unmet demand from patients with relatively minor illnesses. And I think what we must do is recognise that the pandemic is having these after effects, and they're affecting people's ability. Some people may have delayed seeking treatment. Others are having a difficulty accessing the care they need, and because emergency departments have an ever open door, they are ending up in emergency departments, and that is putting exceptional pressures on them. What we're doing, colleagues will remember we published some guidance last winter, Patient First, which was about keeping emergency departments safe when they're under enormous pressure. What we're doing now is bringing together emergency departments clinicians from all over England in a workshop early in June. And what we want them to do is learn from each other about how they can best keep services safe when they are under this exceptional pressure. We've been inspecting emergency departments over the winter period, and we've found many of the similar problems we've found in previous winters, and we've taken enforcement action where necessary. But the pressure is uniform across the whole country, and what we can't do is, if you like, inspect and regulate improvement one department at a time. And so what we're trying to do is bring together this learning by emergency departments across the whole country, and we are bringing them together, as I say, next month, and we'll build on that depending on the experience of that workshop. The second thing I want to go on to is something that is long-standing. It isn't pandemic related directly, and this is safety culture. During the pandemic, we've seen an increase in whistleblowing. Kate was talking about it in social care. We've seen this in hospitals as well. That has been really useful to us because it has helped us identify risk in services. And during the pandemic, of course, we've been driving this risk-based inspection methodology. And the staff who've been raising concerns with us have been really very valuable to us in identifying problems, and we're very grateful to them for that. But I think one of the things we want to do is promote a culture of openness and transparency where staff feel free to raise concerns within their organisations, and those concerns are listened to and dealt with effectively. And that is so important if we're going to see the safety improvements we want to see going forward. And in a sense, we can build on the success of staff's stronger voice during the pandemic going forward. And I think that's going to be an important theme as we go forward from here. A couple of weeks ago, we attended a national summit of national bodies on maternity services. And as I've described before to the board, maternity services are an area where we're particularly concerned about safety culture. And in a sense, that is where we want to start in getting the safety culture right to drive consistently safe care. And we'll be working with national bodies and with local services to drive that improvement in safety culture. At the moment, we're undertaking inspections, safety-focused inspections of maternity services. We have a programme of that underway at the moment, and later in the summer we'll be reporting the outcome of that. but essentially early on, we are still seeing recurrent problems with cultures where people don't feel free to speak up about concerns. And I think that's really important. We have to deal with that going forward. And then the final thing I want to do, come back to what Kate was talking about in terms of closed cultures. We're seeing that as well within the hospital sector, particularly in small inpatient units for mental health and learning disability and autism, in the similar way to Kate is finding. And I think that is something that we've seen continually throughout the pandemic. I don't think it's pandemic related directly, but I think it is part of a long-term pattern of coming to grips with closed cultures in these small organisations where staff perhaps don't have the training, they don't have the support, they don't have the leadership to provide that consistently safe care. And I think it's really important going forward that we make sure the lessons that we drew out in our report, Out of Sight, Who Cares, last autumn, are taken forward if we're going to make a big impact on services in these small areas. And we will, of course, continue our inspection regime, and we will be extending our inspection over this year to make sure that we see the majority of mental health services by the end of the financial year. So those are the immediate areas I want to highlight to the board.
Thanks, Ted. Robert.
Thank you, Ted, for an illuminating report, and clearly a great deal of work is going on by your inspectors behind that. You raised what, in effect, is encouraging the use about whistleblowing and the use it is to us, but measured, I sense, with a bit of a hint that why they're having to whistleblow as opposed to talk within their organisation. What I'd like to know is whether we keep information or know what, if any, are the consequences for the whistleblowers who talk to us. Now, obviously, some of them will have done so anonymously, but not all, fortunately, do that. And I just wonder whether we keep track of that, and if so, what we know about it.
Well, we do keep track of it, and of course, if staff speak to us, we keep that confidential, and we do absolutely everything to maintain that confidentiality to make sure the whistleblowers can feel protected in that way, Robert. Where we do see detrimental action taken against whistleblowers, we regard that as a very serious issue, and it will drive our well-led inspections to look at the safety culture in the organisation, and will be reflected in the enforcement action and the reports we produce. So as we develop our well-led approach, we are going to focus much more on how well organisations listen to whistleblowers internally and whether they take action on that. I should say I can't give you figures on the follow-up of whistleblowers more widely, but we do stay in close contact with those whistleblowers as they're identified and make sure that we keep matters confidential for them.
Good, thanks, Ted. Mark Saxton.
Thanks, Chairman, and Ted, thanks very much for this report. Just listening to you about ED, you talked about pandemic pressure, talked about summer pressures, talked about winter pressures. I mean, really, we're just talking about all-round annual pressure, where we used to just talk about winter pressures. So, you know, your point about transfer of best practice is, I think, absolutely critical, to fend off this ongoing challenge for ED. I thought that your point about safety culture is absolutely right, but could I ask you, to what extent do you feel that organizational challenges are safety factors as well? So I'm talking about tiredness of staff, about roster gaps due to staffing levels, about long-term absence coming from the pandemic. This is a real challenge for the sector, a real well-led element for us to look at, but I just wondered to what extent it's culture versus organizational structure.
I think the way organizations manage their workforce, Mark, is very tied up with the safety culture. I think we know that hierarchical cultures where there's bullying, cultures where staff don't feel supported, where staff aren't trained, as you say, when they can't get adequate rest or their rotas are unsatisfactory, those tend to drive unsafe practices. And I think we've seen a lot, we've learned a lot during the pandemic. I think one of the really impressive things during the pandemic was how staff rose to the challenge, but also how the organisations enabled and supported them rising to the challenge. And a lot of effort was put into support staff during the heights of the pandemic. That needs to go on to deal with the aftermath of the pandemic, but also to build these really important safety cultures going forward. So I think there's real opportunities to learn from that. But workforce is absolutely at the centre. Managing the workforce effectively is absolutely the centre of the safety culture we want to achieve.
So, Ted, you just now said you saw staff in hospitals rising to the challenge. I think your staff have risen to the challenge over the pandemic as well. So I think the board would want to recognise that and pass on our thanks to your teams, please. I think just really interesting. I mean, in addition to all the individual inspections and findings and our normal day job of sort of monitoring and inspecting and rating, I mean, you raised three really big themes there, which we've discussed before, but I think, and I'm sure you will want to come back to the board from time to time and report on progress on safety culture in particular, closed cultures, hugely important. And I think the ED workshop be really interesting to find out what learning comes from that and how that sort of whole national approach develops. So I think really, really important report. Thank you very much indeed. And then if Ted's finished, are we?
Can I just come back on a couple of points there?
Yes, please do. Yeah.
One is I was going to say during the performance report that while the frontline clinical staff have been rightly praised, and I add my praise to that, I also want to praise our frontline staff who had an enormous impact and have adapted really well. So perhaps we can come back to that in the performance report, Peter. And we will come back.
That was all.
We will come back on these various issues. ED. I mean, ED is an issue now, but next winter I think potentially could be very difficult because of resurgence of other winter viruses that have been suppressed during this last winter. So I think there's a real concern around next winter, and EDs need to be well prepared, and we want to do best we can to support that. And as I say, we'll come back to you on maternity services. Can I just clarify, if I said late summer maternity services, it's probably going to be a bit later in the year, but we will come back with a report on maternity services in due course. Okay.
Civil service definition of late summer takes.
Yeah, well, I've just been corrected that I may be raising expectations unrealistically, but later in the year we will produce a report on that.
Perfect. Thank you very much, Ted. So I'll be happy to move on to Rosie.
And can I just echo my thanks to my team as well, who've been working extremely hard, and we'll pick it up in the performance report. But the PMS team have been equally kind of following up risk, supporting other directorates as well, and adult social care and registration with their work, and dealing with a whole range of issues that have been passing through. So thank you very much to the PMS team and all their hard work during the last few months. Access is a key theme I wanted to cover over the next few minutes, if that's okay, Peter. We're talking about oral health access later with the Insight report, so I won't talk about oral health. I just want to focus a little bit on general practice during the next few minutes. And I think I just wanted to echo something Ted was saying, is that we are dealing with a very exhausted, tired workforce who have been working flat out now since last March, and that in itself poses risks to quality and safety because of the burnout that is being experienced by some parts of the workforce. General practice, we are hearing reports of significant increase in demand, particularly in the last few months, and that's due to a whole variety of factors. We've got the backlog of things that weren't done during the significant waves of the pandemic, so long-term conditions management, screening, immunisations, and late presentations of cancers, late presentations of various other illnesses. We're hearing an increase in the number of people presenting with mental health conditions due to the difficult situation. There is an impact of people waiting on long waiting lists on primary care. People do present frequently with wanting help and support during that time when they are waiting, and that has a significant impact. And of course, the vaccination programme that primary care has been very involved in, that is having people are very busy delivering the vaccination programme as well, and that's on also complicated by various issues around certain facilities and estates and the complications of social distancing and various other things in primary care. Just to back that up, the data around appointments show that in March of 2021, 27 million appointments were delivered in general practice, and that is a 20%, almost 20% increase from March 2020, when 22.8 million appointments were delivered. So there has been a significant increase year on year that we've seen in appointments. That there is some caveats around that data because of the quality of data, and there is also a feeling that might underrepresent some of the digital contacts that are had in primary care. On the flip side, we are hearing negative experiences from some patients around access, about not being able to get face-to-face appointments particularly, and we are identifying risks on inspection. We have seen quite a shift in the type of access. Pre-pandemic, 76% of people were seen face-to-face, and in March 21, this figure was 41%, 42% were seen face-to-face with a GP. So there has been a shift. And clearly, in some cases, that's more convenient for a person, but in some cases, it's not appropriate. And we really welcome the RCGP position in this. That they've done a recent report, which was called The Future Role of Remote Consultations and Patient Triage, where their position states the mode of consultation should be determined through shared decision-making between a patient and practice staff. And I think that's absolutely right. It needs to be very person-centred to identify what how a person's needs are going to be met. We're continuing to work with partners on access across the primary care community. And I just wanted to flag as well that through our provider collaboration work, we are identifying really good practice, and we're flagging that. And some of that you'll see in the cancer report that is in the Insight report later. But we want to continue to identify good practice and share that learning as much as possible. I think just going on to Ted's point about people attending A&E and with minor illness, I think it's really important, more so than ever, that systems, local systems work together right across all of the different resources in a local system, and that's pharmacies, optometrists, dentists, GPs, A&Es, all of the community services, as well as the acute settings and the mental health services, to really look at how do they work together to meet patients' needs. There's no doubt there's huge demands on all of the parts of the system at the moment, and the only way through this, I think, is by people working together. And we certainly don't want to get into any situation where we've got different parts of the system saying, well, we're busy and you're not. And I think everyone's busy at the moment, and we need to recognise that, and need to make sure that access is high on systems agenda and people get the right care at the right time with the right person that's going to meet their needs in the appropriate setting.
Great, thank you, Rosie. Any questions, comments? Right, good, thanks, Rosie. Chris.
Coming off mute. Just a couple of things, just one thing to go through in the report, and I'll just come back to some of the comments that people have made earlier. Just to say we've given a couple of bits of information to Parliament recently. Ian spoke with colleagues from DHSE and MHCLP at the Public Accounts Committee. The focus of that was on market oversight and a wider social care stability. He talked very about the fact that most services were rated as good, but 16% of services are still rated inadequate or requires improvement. We talked also about the limited scope of our financial oversight of those organisations, and that's been taken into account in the latest National Public Accounts Committee report that's come out. We at the moment have a financial oversight of about 30% of the market, with 65 difficult to replace providers. We also gave evidence to the Joint Committee on Human Rights, and just to reiterate what Kate said earlier, where we hear the voice of people giving us concern about access to visiting, we follow up on each of those individual cases, and we are very grateful to hear from people, to continue to hear from people and their views in this space. We're writing to the committee again to confirm our position on this, and we also gave some evidence at with Ofsted, alongside Ofsted, the Children's Commissioner, just looking at our joint inspections with Ofsted, and again there was strong support for the continuation of that work. Just going back to something that's coming up, our strategy is due for publication on the 27th of May. I just wanted to say 3 things about that. One is to thank everybody, both internally and externally, for their engagement over the last year on the development of this strategy. We recently took it to an external strategic advisory group this week. There's really strong support for the themes in the strategy, and really strong support to help the organisation arrive at the best solution for each part of that strategy, for each one of those themes. So I just wanted to say thank you to the colleagues, both internally and externally, have made that happen. It's also for us, bear in mind what's happened over the last year. It's the flexible use of both online and offline engagement. So we've used new approaches to engagement with groups of people who use services, groups of providers, and groups of stakeholders that we wouldn't have used before. And actually, we've reached many more thousands of people because of that engagement. So using both face-to-face workshop meetings, which are both online and offline, webinars and recorded events, we've reached many more people than we would have done in a different way. So thank people for their support. Thank people for their continued support as we work on the implementation of those. And then finally, just to come back to a point that Ian made earlier, and I think Kate's made it as well. The last year has been more important than ever to hear about the voice of people who use services. Since the beginning of the pandemic, we know that the voice of people, and in fact the voice of frontline staff, has been critical in our understanding of how services are performing. I'm delighted to say that with a partnership with Healthwatch and with other organisations where we have a joint approach to the gathering of information, we've seen a 60% rise in online feedback using a Give Feedback on Care application, which we redeveloped recently. We've also seen some really strong improvements in both Healthwatch England's feedback and other organisations, other partnership organisations' feedback. We've had a number of spikes of that work, so looking at people with long-term conditions, older people, carers, people with learning disabilities. We've looked at particular groups of people where we were underrepresented in terms of that feedback, from Black, Asian and minority ethnic communities, from other seldom heard communities. We've also had specific issue spikes around NHS 111 and around COVID vaccinations, and we've got another one planned, as Rosie mentioned, around access to primary care as well. These are vital in our ability to take action quickly when we see concerns. And just to reiterate something that Ted said earlier, we do protect the individuals that offer that information, and we use it to guide our responsive inspections. And we've taken on many more thousand responsive inspections in direct response to the feedback we've received from people. And I hope that's something we can take out of the pandemic and learn from. I think the idea of an emotive campaign that also overcomes the barrier of "I shouldn't criticise" being positioned as this is feedback to support learning, going back to Ted's point, a campaign that works for both service providers, partners and others, because this is useful to organisations, and that we do in partnership with wider organisations to represent people's views. I hope very much we'll take that on board as we develop our campaigns into this year. That was all I had to say, Peter.
Thank you. Any questions? No, I mean, Chris, I just think it's really encouraging that we're seeing this steady increase of information from the public, service users, and from staff. And yeah, the more, as you say, the more we get, then the more we can turn that into useful response from us. That's very good. Okay, Ian, we've done the executive team report. Anything you want to add, or should we move on to?
Thank you. Other than just to note the point from Mark about having no significant cybersecurity incidents, we just normally note that as part of the minutes.
Quite right, we do. Mark, I'm sorry, I missed you.
And no problem.
Moment of fame. I missed it. Sorry.
Thank you.
Great. Good. Let's move on then to the quarterly People Performance and Finance report. Mr. Usher.
Thank you, Peter. So it is more than just the quarterly, it is the story of the year. So the papers we included provide a reflective review of our performance in 2021, but obviously in the year that was, our business plan measures only tell part of the story. So our performance team have therefore they've included a 2-page summary which tries to give a graphical representation that rounds up a bit of our delivery and performance in the year. In support of that, we've also got the standard business plan dashboard for the year and supporting analysis, as well as the people metrics. I'm going to hand over now because we're going to do some highlights from the year from each of the exec, and I'll if we come back to me, I'll do a bit on on finance as well. But Kirsty, I think you were going to start us off.
I was, thank you. And then Chris, if you can hand back to me, and I'll do the people bit at the end, if that's okay. So from my space, just a couple of areas I'd like to draw your attention to. I think one is our quality improvement programme. I think this continues to go from strength to strength over the year. We now have more than nearly 50% of our workforce have done their bronze training, and we've got a number of projects on the stocks. We've got over 80 projects that have been that are in train this year. Most of those have been generated by our colleagues on the front line who have identified areas where we can both improve our processes and our ways of working to make their jobs easier and to deliver better services. And I think this just is an indication of the sort of enthusiasm for quality improvement throughout the organisation. It's good to see that that's really starting to take root now. I think we have been looking at our estate over the year. Obviously, the pandemic has made us take some fairly radical moves around moving people out of offices and into a home-based environment. But we were already pre-pandemic starting to think about our office space. And over this year, we've actually managed to permanently reduce our office workspace by 34%. We've now got nearly 80% of our workforce are now being permanently home-based, and I think this is all contributing to our agenda around our overall carbon reduction target, which I think is really positive. The other area I think that's just worth a mention is the work that our colleagues in the NCSC do. These are the people who answer our call line, answer our phones, and process our notifications. They have performed amazingly well over this year. Most of those are our most junior members of staff. They normally sit in a call centre environment in Newcastle, where they have a lot of support around them in terms of floor workers. With the pandemic, we moved every single one of those to a home-based environment, and we have managed to maintain a service of answering the telephone within our target calls. And they've handled well over 112,000 notifications just during April and May alone, which was significantly higher than they had been during the last period, and we've continued to do that. And then just finally from me, I think within the registration space, we've processed nearly 30,000 registrations over the year. We have also managed to prioritise our activity in response to COVID, so that we were able to prioritise those applications that were adding capacity in the system to support the COVID response. And as part of that, we've also been fairly innovative in terms of how we've worked with providers to ensure that we can bring on capacity quickly. And a really good example of that is how we worked with NHS England to support the establishment and registration of the new Nightingale hospitals. So shall I hand to Kate next?
Can I just emphasise something you just said, Kirsty, which is that some of those 112,000 calls can be, you know, quite distressing for the person receiving them, and the support that would normally have existed by being in the office is obviously not there. And I just think we need to sort of recognise that and doubly thank the people taking those calls for the way they've handled them and their resilience in handling them, because it's not always very easy, to put it mildly.
No, they have done a really sterling job in difficult circumstances.
Yeah, absolutely. Right. Are we happy to move on then? Who's going to speak next?
Shall I go next, Peter?
Fine. Yes, I've completely lost the plot. So go for it, Kate.
So there's so much I could talk about in terms of adult social care inspection activity over the last year, but I'll try and just home it down to a few key points. I think the first point I'd make is the kind of flexibility of our staff to adapt new ways of working. So the focus at the start of the pandemic on increasingly emphasising the supportive relationship we had with registered providers and the ability to escalate their concerns and take action when needed. We've developed new methodology throughout the year. So obviously we've had the new approach to having structured monitoring calls. In adult social care over the summer, we developed a kind of bespoke inspection around infection prevention control with a real focus on ensuring providers were delivering safe care. And then in the autumn, in response to recommendations from the Social Care Task Force, we responded to the government's request for designated settings to be set up across the country so that people leaving hospital with a COVID positive status whose long-term destination was a care home had an interim ability to stop so that they could receive their care until they were able to move to their long-term care beds. So on the designation settings, we approved 144 locations, which equated to over 2,100 beds. And then just a bit in terms of the big numbers. So for the last financial year, adult social care did 6,369 inspections throughout the year. And as I mentioned earlier on board, 70% of our 25,500 providers had a regulatory intervention or activity from our staff. And I suppose just to finish on, whether it was our inspectors that were outcrossing the threshold, or whether it was our inspectors who for various health reasons were inspecting from their home, whether it was our directorate support colleagues or our staff in management or market oversight, everyone has had a role to play in ensuring that people have got care that they've needed over the last year. So just a big thank you to every bit of the organisation in terms of enabling my inspectors to get out and make sure that people are getting high quality care. Thanks.
Thanks, Kate. Rosie.
Thank you, Peter. Just to echo what Kate said, our teams have learned multiple new methodologies over the last year and adopted them very, very quickly. We've had the emergency support framework, the transitional monitoring approach, the PRA as well, and also in PMS we have, in general practice, we've introduced a new way of looking at clinical searches to identify risk as well, which is something we can do off-site and has been very effective at identifying areas of concern. We've undertaken just over 300 inspections over the last year, about 240 of which were risk-based and the rest were regulatory history-based. But as well as that, we've also undertaken a programme of looking at our special measures practices and re-inspecting those. And I'm really pleased to say we've seen significant improvements in many of those special measures practices. We're just working through the data and the learning, and I hope to include something in forthcoming board reports because we've seen some great improvement in practices despite all of the challenges that they've faced during the pandemic. We're continuing to work with local partners in those practices where we haven't seen improvement to make sure that those improvements are made. Our current focus is looking at going back to requires improvement practices to make sure likewise that the improvements that have happened are continuing, and we're following up our areas of regulatory breach as well. The other thing to mention is our teams have undertaken over 2,500 TMAs during the last year, which has proved to be a very good engagement tool with providers, and we've had lots of positive feedback, particularly from our oral health colleagues about how they've welcomed the engagement and the support that's been given through those calls.
Excellent. I was just pausing to see if anybody wanted to come in, but nobody does. So Ted.
Yes, thanks, Peter. And just again to pay tribute to my colleagues, in what has been a very difficult year, they have achieved amazing things. And I think it is difficult to underestimate how radically different our approach has been during the pandemic, and how we've managed to implement an effective approach to regulation, turning on the sixpence from our old approach of timetable comprehensive inspections to our new approach of risk-based inspections. And I pay enormous tribute to the staff who managed to get this methodology up and running very quickly, and have completely changed the way we've been regulating over this last year, making sure that we're supportive of trusts and providers, but focusing absolutely on the risk that's been identified that I was talking about earlier on. And even despite that, despite the pandemic, despite this approach, we've been interacting on a regulatory basis with more providers this year than we ever planned to, because we've been using all the other tools that the colleagues have talked about, such as the TMA, such as the vaccination monitoring approach that we had to look at vaccination centres. And those things were developed very quickly and have been applied very effectively in making sure that we have a real breadth of regulatory spread across services. The TMA we've done for all independent health providers across the country. So we have a real sense of independent health risk at a time when a lot of the focus has been on the acute sector dealing with the pandemic, where we've been supportive, but focusing on areas of risk that I talked about earlier on. I also want to pay tribute to my colleagues in the Mental Health Act review team and the SOAD team, the second opinion appointed doctors team, who have been really changing the methodology and the approach to Mental Health Act reviews over the year, and managed to maintain a really focused service to make sure that we've fulfilled our duties under the Mental Health Act to review mental patients detained under the Mental Health Act of the year, and make sure they're consistently getting the right support. And it's been so easy to neglect such an important sector during a time of pandemic, but they've developed virtual approaches that have been really innovative in driving forward that approach. And of course, we will learn from that going forward. So while we're not going to stay virtual, we will learn from that virtual experience going forward. And one last thing I want to mention is, and Kirsty mentioned this earlier on, and this is quality improvement. And I think one thing that the Directorate has been doing this year, which has been really successful, is implementing quality improvement initiatives and taking on board and move towards a real quality improvement driven agenda and culture within the organisation. And they've done some really great work. They've done some work about induction, which has been really good at welcoming people into the Directorate over this last year that we've recruited. They've done work around how we manage whistleblowing and safeguarding, and they've done work about how we produce reports, produce them more quickly, more succinctly, more consistently going forward. And that has all been work going on in the background while we've been managing the pressures of the pandemic. So I think in many ways it is we've come through the pandemic incredibly well as a Directorate. It's been really challenging at times, and pressures have been felt by those people who've been worried about the infection and going out to inspect. But having said that, I just want to pay tribute to all of them and what they've contributed over this last year.
Thanks, Ted. And I think the point you made, that we have adapted and learnt a lot, and that's great success. And what we now need to do is to work out how much of those different ways of working we want to retain, how much we want to further develop, and how much of what we used to do we want to bring back. And I think that's going to be really important. But it's been a fantastic opportunity in a strange sort of way to be able to experiment and learn at a pace in a way which we probably couldn't have done in other circumstances. Can I bring Mark Sutton in, having failed, Mark, to give you your moment of glory on the cybersecurity earlier? Either you're
Thank
on.
you, Peter. Sorry, I was just struggling to come off mute. Apologies. I think I'd just echo what colleagues said earlier on about the new way of working over the last year. I think for us in digital, it's been a huge opportunity for us to accelerate some of the transformational work that we'd already had planned and underway. So the support of the organisation through the emergency support framework and the transitional monitoring authority application has enabled us to embed some of the technology earlier and roll it out earlier than we had originally planned for, which I think has been a great testament to not only the technology teams and the suppliers that we've worked with in order to enable us to achieve that, and to enable us to continue our regulatory activity through the pandemic, but also to the organisation that have embraced this new way of working and this new technology to help us to do our work. And I think just looking at the fact that over the last year, we've been able to, through this method, had some kind of regulatory contact or activity with over half of our providers throughout the last year. I think that's a great testament to the teams working very well, and that foundational work is really standing us now in good stead as we move forward with the development of our digital platforms to support our strategic aims in the future. So looking forward to smarter regulation, our Microsoft Dynamics solution that we've implemented through the emergency support framework and the transitional monitoring application will essentially morph to become our new regulatory platform, and enhancing them and extending them to provide better services for our colleagues internally to be able to carry out their regulatory activity, to give them more meaningful insights, but to also provide better digital services for our providers that we regulate, and to be able to deliver not only much more efficient and richer services online to our providers, but to be able to provide much better, more insightful information to the public as well.
I think it's also worth adding, Mark, that the work that you and Kirsty led earlier before the pandemic, whether that was telephony in the call centre or Office 365 or whatever it was. I mean, we were actually in a much better position to be able to move to new ways of working than we would have been had we not done that work, and if the pandemic had hit, a year earlier or something. I know we're not the only organisation who can say that, but I think we are particularly well placed thanks to the efforts of your team and Kirsty's team.
Thank you, Peter. Yes, I think the technology that we've embraced around collaboration has really supported us well, and the ability for us to essentially move our contact centre completely online and to be able to work remotely from people's homes, I think is a great achievement. Again, both a technology achievement and an achievement from our colleagues to rapidly adapt to that new way of working, but stands us in enormous good stead for the future as well, because I know a lot of the successes that we've had will continue to support us well in the future as well.
Yeah, Ian.
Thanks, Peter. I mean, I think the aim of the game at the beginning of the year really was to have a credible tactical response to what was an emerging global pandemic. But in doing that, we also tried to make sure that our strategic ambitions, and you've touched upon some of them there, continued as well. So some of the big strategic pieces, investment in the technology platforms, reducing our office footprint by moving out to Stratford, all of those sorts of things. We tried to continue to do those things at the same time. We also invested in some of the cultural pieces that Ted was talking around process improvement, all the time aiming to try and make sure that we were a credible partner to government where that was appropriate. We were doing what we needed to do as a regulator in terms of delivering for the public, but also setting ourselves up for the future so that we could we could learn the lessons from COVID and come out the other side in a way that satisfied all of our stakeholders. And I think we've largely succeeded. I think there's always going to be things that we will want to do more of and better and so on. And I think we're all concerned about the lack of being able to come together during this year, which has meant some of the pieces around our cultural change are possibly not necessarily completely there yet. But I think we've certainly made some really good strides during the pandemic. So that notion of bringing the tactical and the strategic together and making progress on both agendas has been a factor that we as an exec team have tried to pursue. And I think these figures really sort of summarise the year really well. I know Chris wants to talk about the money in a minute, and Kirsty wants to finish off with some of the people measures, but that was sort of the summary of where I wanted us to get to. Thanks, Peter.
No, thank you, Ian. Just before we come on to my favourite subject, the money, can I just bring Chris Day in, please?
Actually, to be fair, Ian said a lot of what I was going to say. I think the ability for us to operate both tactically and strategically in real time has been really important. An example of that is a COVID Insight report and a weekly IPC report. So they bring data and information together in real time to drive policy debate and understanding at the centre and locally. I think the technology around Give Feedback on Care has made a significant difference. Without the investment that we made earlier in that work, we would not have been able to see the increase that I talked about earlier in terms of Give Feedback on Care. And I think the ability to have ongoing conversations with people during a pandemic about important issues like LD services, like infection prevention control, and to make sure we can have conversations both with people who use services and that accountability to Parliament has been critical, providing the right information at the right time to drive the government policy agenda. So I think there's much to learn from what we've experienced over the last 12 months as we look ahead to how we implement the strategy well and continue that policy development.
Thanks, Chris. So, Chris Usher, am I going to have to leave a note to my successor to say there is no more money, or are we okay?
I think we're okay. Yeah. So on the revenue budget, we ended the year 10 million underspent, which largely reflects the impact of COVID on our activity. We'll retain that underspend, and that'll support future regulatory delivery and also our transformational change agenda, both of which would benefit providers in the medium to long term. On the capital side, we were 400k underspent, with obviously expenditure largely supporting our transformational change. I think that's the most capital expenditure we've incurred possibly ever, I think. So it's a good delivery on our capital budget and aiming at helping us to support our change agenda. So that was the main bits I was going to cover. I know Kirsty wanted to talk on the people side as well, but I don't know if cover that off under the change update.
Yeah, just a couple of points. I have got some more sort of up-to-date people stuff in the change update, but just to sort of in terms of this year's performance around our people. I mean, I think it has been quite a challenging year in terms of the people front. And a lot of our colleagues have suffered a lot of distress with personal loss, as well as working in a difficult scenario. So we as an organisation have tried very hard to support our people with a lot of wellbeing initiatives and making sure that people have access to support services to enable them to cope as best as possible. And I think we've had a lot of people who've been isolating and having to work in a very in difficult circumstances. And I think as an organisation we have pulled together to support our people as best we can. As well as that, we've done quite a lot of work in terms of making sure we can continue with our fairly extensive programme of training. The team did a fairly phenomenal job of moving all our in face-to-face training online and have continued to deliver a fairly extensive programme over the year with minimal disruption. And we've also continued to work on our programme of cultural change, as Ian alluded to, by developing some of the work around supporting our managers and developing our success profiles and really setting out some of the sort of behaviours and ways of working that we want to see going forwards. And we've managed to continue to do that, albeit in a remote way. And I think, again, a testament to the team who've been able to continue with that work in quite difficult circumstances where they've been challenged in terms of just keeping the show on the road, in terms of making sure people are still supported, and we've managed to keep the agenda going. It's been a huge amount of work on our D&I initiative, and I will touch on some of that later in the change programme work. But I do think that has been a key element of some of the work we've had going forwards. I think we've done some really interesting work, particularly around the listening events and strengthening the work that we are doing to support our Black and minority ethnic colleagues, both in terms of making sure that their voice is heard, but also in terms of putting structural support in to ensure that we're able to support them to be to fulfil their potential and career ambitions over the year as well. Thank you. Thanks,
Kirsty. So we've heard from everybody. And we've obviously got a massive amount of other data in the board papers. So let me just open it up for anybody who wants to come in. And I know that Mark Chambers, you do want to come in. So Mark.
Thanks very much. Yeah, I wanted to come in on one of the on one of the people points in the pack. Peter, you talked earlier about the extraordinary resilience that folk in our contact centre have had to show. Often, some of the more junior people in our organisation doing an already difficult job under extraordinarily challenging conditions without the usual support infrastructure of colleagues and managers sitting in the same physical space. We've heard quite a bit about the wellbeing support that has been provided. I think that's been innovative. I think it's been timely, and I think it's been very well targeted. I think it's been really encouraging to see that. Just an observation though on the sickness absence rates, and that we've got very low sickness absence rates. One of the things that sort of worries me a bit in an environment where we have 80% of our people home-based is one of those insidious pressures, a bit like presenteeism, that you can't be sick if you can manage to physically work, and the pressures to work while unwell are the same pressures that there would be in an office-based environment, but good managers in an office-based environment would have the trigger of somebody emailing saying or phoning saying, I'm ill, I'm going to work from home, and then the opportunity for the manager to say, no, you're not. What needs to be delivered today? How can we reprioritize it? How can I manage expectations? How can I take that off you, but concentrate on getting well? How are we addressing that particular risk of pressures to work while unwell?
Shall I answer that?
Yeah, Kirsty, please.
Yeah, so we are very conscious of, I suppose, the underreporting if people are home-based working and they're sick, because they can carry on. And so we have been really proactive about telling people if they are ill, not to report, not to come in and not to work, and making sure that we are telling people to record if they are ill, so that we are having those conversations with managers. I think we don't want presenteeism. If people are really ill, they need to be at home and off. But I think historically we have had generally quite low levels of sickness in CQC. Our statistics and our performance around sickness is generally pretty good. So I don't think we haven't seen a sort of massive drop off as more and more people have been working at home. But just to remind you, we've had 60% of our workforce home based anyway prior to the pandemic. So our managers are quite well versed in managing people remotely and making sure that they work well, they work when they're well, and they don't work when they're not.
And at the risk of being criticised by Rosie or Ted, I mean, I think the fact is that if you are home based and you're not going out in as much as you used to go out, you are much less likely to get all the normal winter ailments. So you would actually expect, to some extent, sickness to have gone down, strangely enough. So since nobody's jumped in and said that was rubbish, let's move on. Mark Saxton.
Won't comment, Chairman. No, thank you. I wanted to talk about the year at a glance. I thought it was super to hear from everyone on that, but it's a great, it jumps out at you on the screen, especially comparisons to previous year. So, you know, to do all that and still outperform the previous year, super. I suppose the downside is that I think I've had to learn 5 new acronyms, but you know, that's language that we've developed in this 12-month period. So ESF, TMA, IPC, DS, and PRA. I mean, it's remarkable. So well done. Congratulations. I think it feeds right through to the performance charts. If you look at the regulatory activity chart on page 33, our risk-based inspections, as Ted was referring to, you know, clearly increasing, and our consistency improving. I would like to talk a bit about the new charts in the performance pack on the people charts. So equipping our people and our organization to deliver our purpose. I think these are great charts, but they give some good information that quickly trying to scroll through to get. But one of the things I wanted to make the point about was in terms of our D&I and our turnover. So if you look at starters by ethnicity, that's significantly higher than our workforce by ethnicity, and our leavers by ethnicity is lower than our workforce by ethnicity. And in terms of the labour market, we are above the labour market. And I think that's an important message, and it's one that we will continue to watch. I mean, interestingly, following on Mark's sickness and well-being, one of the reasons we wanted this chart to come to the board is that you can see that actually over the period, we've seen an increase in absence for mental health over the last 3 years. And if you go into the grades, you do see grade C having an even higher percentage of mental health being the cause for absence. Now, I know that, and Kirsty is going to refer to it in her later report, that we've done the Mind Workplace Wellbeing Survey. And I just think, you know, it'd be great to hear those results. And the way this report, Equipping Our People report, has been structured, we've got the opportunity to dig down into what are we doing around grade C, what extra support are we putting in for that group that you know have that higher rate. And I would just ask us to consider that might be a good thing to do. And again, looking at our turnover charts, the movements by grade, the starters, the promotions, the acting ups, the leavers. I mean, that looks a really, really busy chart. And it is, but it, you know, it has a lot going on in it. And I just think, again, that can really support our D&I initiatives. So we could, for instance, look at grade B, where you can see a lot of churn, and look at that by ethnicity as well. And that, I think, would be an evidence of our look and our actions at a board level to support D&I. And finally, I suppose the disability percentages still are low for us. I think that is a self-certification issue. I think it's one that the people team will continue to look at. But I'm really pleased to see these charts in the pack, and thank you for providing them.
Thanks, Mark. Some really great comments there. Kirsty, is there anything you want to respond?
No, I think we have regular conversations. I know Jill and Mark have regular conversations outside of the board to sort of make sure we're providing the data in a way that's helpful, and happily take feedback from other board members if there's anything else that people would like to see in the pack in terms of a better view of our people and our movements within.
Thank you. Thanks again, Mark. Robert.
Thank you. It's just a slightly off the pitch question, but firstly, this is really useful information, and the way it's being presented, I think, certainly passes what my test for actually being capable of being digested and understood. So thank you very much. I just wondered, it's a bit hot off the press, but the NAO published a report this morning reviewing the government's performance during COVID on a number of issues. And I just wondered, although obviously it is addressed at the government at what it did or didn't do, I wonder whether we are going to or should consider what lessons, if any, there are to be drawn out of it for ourselves. I noticed that it says, and I've not read it in full, but it says quite a lot about the importance of the consistency of communication with the public. Needless to say, it says a lot about planning for the unforeseen. And it says a lot about the support for the well-being of staff. And I suspect in all those areas we probably don't do too badly, but I just wonder whether it would be just a useful check. It's only 48 pages or so, short for a report. Be worth just checking. Also, perhaps looking a little bit at what our contribution was either to the positive or the negative parts of what is said there.
So you're ahead of me, Robert, in actually having read the report as opposed to the media coverage of the report.
Well, when I say read, I've skimmed through it and I looked at roughly what's there. And as I say, it is one of those unusually clear reports, actually.
So if it's that easily digestible, I'm quite sure that we will look at it and read it carefully. And if there are learning points for us, Ian, we will pick them up, won't we?
Yeah, absolutely. I mean, we are doing some work in terms of timelining what did go on during the pandemic, so that we are ready for any subsequent more formal inquiries. But yeah, I'd like Peter, I haven't read the NAO report in any depth, but it's something which I'm sure we can do. But yes, absolutely.
Thanks, Chris.
Just to say, we were helping the NAO with their compilation of this report. So I think the majority of the issues are for government, but certainly if there are issues that parallel we can learn from, that we should. And as Ian said, there is a series of pieces of work we're doing at the moment to look at the decisions that we made and what we can learn from those over the course of the last 12 months. So that piece of work will come to the executive and to the board in due course. I think this report today, we've helped in terms of the information that we've provided that helped contribute to the report. And certainly if there is anything for us, we've had a couple of conversations with the NAO already. We'll pick them up. We'll pick those up in conversation, and it'll add to our learning that we bring back to ET and board.
Great, thanks, Chris. Sally.
Thank you. Just on the learning lessons from the pandemic point, regulatory governance was yesterday, and we've already looked at 2 of our directorates in terms of what's gone well and what's not. So in some senses, we're ahead of the game with the 3rd to come next month, which I think is really positive. I just wanted to say thank you for the pack. I think it's much more expansive than the ones we've had previously. I know it's a year-end special effort, but there are some really useful facts and statistics in there, and they reflect just how much has been achieved over the last year. So I welcome something like this going forward. Thank you. My point was about keeping in touch with our staff when we have so many home workers, and particularly as we are implementing a new strategy, new ways of working, and things are going to change post-pandemic. So I noticed only about half of people have an exit interview, and some of the other factors that Mark Saxton pointed out before. And I just wanted to ask, are we definitely keeping in touch with both people who are still here and working for us, despite their mental health struggles and potentially being alone? And do we take the information from people who are leaving to try and think about improving our policies?
Chris, were you going to reply?
I was just going to talk. I can talk to part of that, which is about the ongoing engagement with colleagues. So each week we do, as part of the sort of summation of all the conversations we have with colleagues, we do a sort of weekly report, which is actually principally for Ian and myself, that goes to the wider ET as well, just to look at some of the key themes of things that the conversations that have been this week. And that's a really good guide, first of all, for future conversations that we need to have with colleagues and further explanation. We also use it as a conversation piece for the SLT 30 and the wider 120 group, so that leaders feel empowered and able to have good conversations with their team, because part of this is, particularly as you say, with a home working population, it's giving managers the ability to engage well with their colleagues who are working remotely, so that they have access to the information at the right time. So that report comes in weekly, and it sort of picks up on some of the key themes from Ian's calls, some of the key likes, if you like, in the comments that come through that, and that we use that to guide further conversations. And we also use it to sort of feed out to managers the information that will help them to make a better conversation with their colleagues. And we aim to do that, particularly as we talk about the strategy rollout. What are we saying when? What are the implications? Where do we want involvement? What's happening next? Those are the messages that we want to make sure both leaders and colleagues across the organisation understand and know. I know that only answers part of your question, but hopefully that gives you a sense of how we're maintaining the engagement with colleagues in the organisation.
Kirsty.
Thank you. So yes, in terms of exit interviews, we do try and have as many of those as is feasibly possible. The team do collate the information that comes from that, and we then do use that to look at any areas that we might want to adjust in terms of why people are leaving. You can see in the pack, it gives you a sort of sense of the questions in terms of why people are going, and there's some things where we have people leaving well, and that's always really good, where people are going on promotion and things like that. And it's the ones where we're leaving not so quite so well that we do want to really dig into and understand and use our data, particularly if we've got areas where people are saying they're leaving because they don't like their line manager, or areas like that. We do follow that up to see whether there's any training or additional input we can make to support those areas of the business.
Great, thank you. Kate.
Just very briefly on the exit interview point. So we've had some conversations within our directorate about how we can get that number up, and some suggestions that's come up that we need to think about and probably talk about at the people board was a suggestion that people might be offered an exit interview with someone from a different part of the business. So maybe you don't want an exit interview with your line manager or your line manager's manager, but actually maybe having someone from a different part of the directorate might be something that would help get those numbers up as well. So it's an active conversation. It's definitely something we want to see more of, because that feedback is so critical.
Great, thank you. So, board, are we happy to note the year-end performance report and the financial position? Excellent. Thank you very much, executive colleagues, for all the work in putting that all together, but more particularly for all the work over the last year, which has been phenomenal. Thank you. So, Kirsty, we're back with you, I think, with the change report.
Oh, thank you. So thank you, Peter. So in terms of this paper, I am just going to run through a few areas and just pull out a few highlights. I think over the last quarter, we have continued to make some really good progress over the portfolio of change, making sure that we are aligning our activities so that we can build capability and capacity to realise and support the development and implementation of our new strategy. As part of that work, we've been reconfiguring the portfolio, and we've now looked to build that into three areas. The first one of those is around developing our new regulatory activity and looking at how we want to regulate going forwards and setting a programme of work around that. The second area is focusing on how we create our structures, our skills and our capabilities that we need to take us forwards. And then the third area is looking at how we build our new technology, our new systems and processes to enable our new ways of working. That piece of work is now is coming to fruition, and we are realigning the whole of the portfolio to enable us to deliver against those three key areas, and we'll continue to report out on that as we move forwards over the coming year. As part of this work, we're now focused on mobilising that portfolio, and particularly making sure that we've got the right resources in place to deliver on our ambitions, and particularly understanding where any risks may sit in terms of our ability to recruit in key skills. In terms of the programmes that we've already got in flight, these programmes are ones where we're continuing to build our capabilities and services, such as registration transformation, developing capability around our data and insight, and building on our new regulatory platform. Those programs are continuing to make good progress and are on track, both in terms of delivery and in terms of our planned expenditure against them. In terms of the people front, we've had another busy quarter. We have launched our new talent management framework this period with a view to enabling our colleagues for all of our colleagues to develop their careers whilst they're here at CQC. This is not just focusing on our brightest and best, but actually creating a platform in which everybody is able to build and develop their skill set. We've also continued to hear our employee voice through our pulse survey work. The last survey was in March, where we focused on people's experiences of working at CQC, and particularly with a focus on our diversity and inclusion agenda. And then our next survey is planned for sort of late June, early July, and again that one will focus on well-being. We continue to pull this data to give us a really up-to-date and continual feedback in terms of taking the temperature of the organisation and giving us some helpful steers and feedback in terms of what's landing well and where we might need to focus our attention as an executive team. We've also, in this last quarter, published our Workforce Disability Equality Standard and our Workforce Race Equality Standard. This is the first time we've published the Disability Equality Standard, and we're really pleased to be able to do that. As part of our D&I strategy, we also have launched our reverse mentoring scheme for our Black and ethnic minority colleagues. This scheme has paired senior leaders with more junior colleagues to talk about their lived experiences, not just at CQC, but just in terms of their lived experiences in more general, and really built some positive relationships there. We had a sort of a review of that earlier in the month, where colleagues came together to discuss their experiences of the scheme, and really we received really positive feedback, particularly from those junior colleagues who've been paired with senior managers to hear that, so we can hear their stories. We've also continued to build on the work of our success profiles and have now incorporated these into our performance management approach, with colleagues now setting their objectives for the year, both based on behavioural objectives set out in the success profiles, and also the task-based objectives that we're looking to see. So that's a quick summary from me. I don't know, Mark, if there's anything you would like to add in terms of the tech change programme.
We lost you. Have we lost you?
That's it. Apologies. Yeah, just a few things from me. So it's been a really packed quarter for digital and intelligence. We've made really strong progress in our key programs of change, which essentially are the regulatory platform, transforming data and insight programs, and regular continuous technology improvement. In regulatory platform, we've continued our transitional regulatory activities we were talking about earlier on throughout the pandemic, and that's included not only the transitional monitoring, but also infection prevention control assessments and designated settings in adult social care, and also now the monitoring of large-scale COVID vaccination centres. But our core regulatory platform foundation work is going really well. The foundation's been established. We've introduced new data architecture and data synchronization with legacy systems, and we've established the foundation of a new digital portal for our providers, which will lead to really significant improvements both for CQC and for our providers as well. And we're building the foundations now for our smarter regulation strategic goals, with new applications for our regulatory colleagues for monitoring, assessment, and for registration as well. In data and insight, we've completed a business case for our Transforming Data and Insight program, which will deliver the organisational and technology capabilities which will support us in becoming a truly insight-driven organisation. And we're going through the final stages of those approval processes now. But in the meantime, we've delivered a really successful proof of concept, which demonstrates that the new technology supports a number of business use cases, such as real-time views of health and care systems, which gives real-time insights graphically, and the ability to have really granular insight down to the level of an individual provider's data in a visual form at the context of the point at which an inspector is looking at quality assessment in question. And in our continuous technology improvement, our service and security operational centre is unbelievably shortly going to be celebrating its first anniversary, and the customer satisfaction on that is regularly hitting 95%. So I'm really grateful for our technology colleagues and suppliers and CQC colleagues for making this recent transformation such a success. We've completed a rollout of our new Windows 10 laptop image to improve the stability and reliability of colleagues, which has involved a physical swap for everybody, and that's no mean feat when colleagues have been working at home for well over a year, often with very different home setups. But this sets us up really well for the future, which gives us the ability to manage our estate and future updates remotely. And we're also investing in our people across the organisation, making available training courses in the new technology that we're adopting, with a number of colleagues taking courses and getting accreditations in the new technology, Microsoft Azure, Dynamics and analytics expertise. So a really good quarter of progress in transforming our digital intelligence capabilities, and we'll continue to progress with that over the next quarter.
Thanks, Mark. A 95% satisfaction in anything is quite amazing. So well done, brilliant. Any more from anybody on this, or are we happy to note and move on? Okay. Oh, sorry, Mark Saxton.
Thanks, Chairman. Sorry, I know you're in a hurry, but I would just like to say that I think that the People Report is a really great insight into our planned and considered management of our people and stepping ourselves towards being, as we want to be, a first-class employer. But I've got two questions. We continue to recruit over 200 joiners in the last 12 months. We know that the transformation process requires specific roles that are difficult to fill and challenges our existing resources within the organisation. So, successful recruitment requires agility, requires engaged recruiters, and where appropriate, effective partners. I just wonder whether in the next quarter, could the resourcing report just give us some insight in how we're going forward and being effective in this area, and steps we're taking to continue our positive ethnicity recruitment performance? Just if we could have that in the next quarter, I think that would be helpful. And, we've seen in the main board pack today a really helpful people report and demonstrating the quality of the people analytics. I just wonder, does that tool go down to supervisor level? So do supervisors get their own report that supports the well-being of their teams, encourages training and development of their teams, and effective recruitment at this level? So it's just whether that data pack gets to the front line.
Yeah, so in terms of the data pack, every manager has access to their data at a team level, so they get that level of detail plus more, actually. So they really they're able to sort of put a finger on the pulse in terms of all the bits they need to access. So that's definitely available to them, plus the data that comes out through Chris's team in terms of the performance piece. So they have the people data and the performance metrics data comes together. So there's an awful lot of information for them to access. In terms of the recruitment piece, yes, we could certainly bring a bit more detail in that. think, as I said earlier, we are looking, we're segmenting our recruitment by type so that we can really understand the risks around particular skill sets and look at how quickly we're able to recruit into those, or what our turnover rates are for those particularly sought after skills, so we can really understand and manage that risk better. And that's a piece of work that's in train at the moment, and we'll certainly happily bring that back next quarter for you to have a look at.
Great, thank you.
Good. So I think we can say we've considered the report and we've noted it, which is what we were required to do. So shall we now move on, Chris, to you?
Yes, so the latest insight report, Rosie talked about it a little bit at the start. I know we haven't got long, so let me just try and do a quick summary. First of all, the insight reports are about sharing good practice about what's going on, and also talking about some topics that we are concerned about through our regulatory activity. This report focuses on two issues: what we're learning from the good and outstanding practice in cancer services, and also some concerns we have around dental access. Dental access has been an issue long before the pandemic. At the start of the pandemic, routine NHS services were paused as practices introduced infection and prevention control measures to help prevent the spread of COVID. Practices holding NHS contract were advised to provide advice on pain relief and antibiotics, but not to do much more. From about June, practices steadily restored their services while introducing stringent infection prevention control measures and using additional PPE and allowing sort of fallow time between inspection activities. We know that there's a financial challenge that was raised by some practice in relation both to the purchase of PPE and to the cost of those changes and what they can manage with a reduced number of clients. And this has raised a sort of potential concern around access to services more generally. What we're seeing in terms of feedback from people who use services is that there's a strong sense of people, on one hand, being very grateful to get access in an emergency, but at the same time, a lack of access, a general lack of access. We've seen a rise in people accessing 111 services and other emergency services because of their lack of ability to get access to dental services. We know that the feedback that Health Watch England have received has expressed the same sort of concerns. And if you look at the numbers, about 58% lower activity in 2020 compared to 2019. That activity has to go somewhere. It's going into a combination of NHS 111 inquiries and, unfortunately, emergency services treatment. So we know there's the concerns there. We know there's some issues around how organisations can staff well and schedule well because of what's going on with the pandemic. We know the issues around access to technology and to what extent can technology support that. We know there's been some really good work in terms of vulnerable groups and how some dentists have responded, being more proactive in their access of vulnerable groups to make sure they've got the services that they need. And we know there's been some patchy work on system working, some really good examples of where dentists have worked well with community-based pharmacies and other organisations, but a lot of occasions where dentists don't see the relationship between themselves and, for example, a GP or indeed an adult social care organisation. So what the report just seeks to do is to sort of raise some questions that we think we need to explore further. So this is about the confidence that that there is in terms of the access to NHS dental services. Are they available for everyone? In terms of urgent dental treatment, what measures are taken to prioritise and improve the access to 111 and use that service to prioritise access to services? In terms of commissioning access, is there enough dental capacity being commissioned at the moment? Are NHS colleagues clear about where the demand for those services are, particularly around people who are vulnerable? And also access to oral and dental health in the future of an integrated care system. How do we join up those services? We had a report a couple of years ago, or a year or so ago, which talked about oral health in care homes, which is there were tremendous examples of where services have really joined up, but not enough of that across the country. How do we make sure that integrated care systems fully focus on dental health as part of those services? I can stop there. I'm going to move on to cancer services. What would you like to do?
Yeah, let's stop for a second. Let me bring in Robert.
Well, firstly, thank you very much for this report, and I just really wanted to make two comments. One was, it's a good example of the collaboration that can produce a result and information between Healthwatch England, who issued a report on this very subject at the end of December last year, and the CQC, and I think it is an example of how our strategy going forward of feeding off people's experiences can produce powerful information. The other point really was what next. Chris has sort of to some extent talked about that, and of course a lot of what needs to be done. And by the way, a lot of this stuff, as I think you point out, is as the pandemic has exacerbated what was already there. But is what next? And I appreciate it's not for us necessarily to put solutions in place, but I would hope that we will follow this through, so that, because there's been a habit, certainly at Healthwatch, and we want to change this too. We issue a report, and then someone's going to do something about it, and we go on to the next project. But dentistry is an example of something that's been going on for years like this, and somehow it seems to me that between us, we have a duty to keep on top of it.
Yeah.
Thanks. So let me bring in Stephen, and then Rosie will give you the last word on dentists, since they're within your bailiwick. Stephen.
Thanks, Peter. And really, it's following up Robert's point, because I think this model of producing reports, what are we learning from COVID, is really, really helpful. I think it's a fabulous example of how CQC can use the information that we have, the insight that we can create. So I think it's a really, really good model. But in this case, it sort of led to putting out there into the ether some quite big questions about, so how could we make this better? Whereas in a sort of typical CQC inspection report, it would be clear what the follow-up was and who was responsible for taking that follow-up. So I'm interested in kind of this as a model. We're putting out some concerns, some issues, some questions. Is it clear who is then responsible for following it up, for saying, OK, that concern has got my name on it, I better do something about it? Where does it go?
Shall I come back on those things? So thank you, Chris, and thank you for the questions. And just firstly to say, this has been a great piece of work done by the dental team. So thank you to all the team involved in that at quite a rapid pace. And as Robert said, we have worked really collaboratively with Healthwatch, and there's a really good partnership arrangement working with Healthwatch and sharing information and looking at how we can pull on the intelligence that both organisations know. We are following up. This is probably one of my major areas of concern at the moment in terms of dental access. And I think, as Chris has said, it has really exacerbated inequalities, and we've seen that inequality gap grow. And I think I want to give absolute assurance to the board that this isn't something that we're going to write a report and then forget about. It's absolutely something that we're continuing to work on. We run a dental reference group where we work with all of the key stakeholders from all of the different dental stakeholders, and we meet with them regularly. And these issues have been absolutely recognised with those stakeholders, and we will continue to work with them to look at how we can influence and encourage organisations that to take up the recommendations that we can't influence ourselves, because some of these are outside of our control because of the way our legislation is set up at the moment. I think we're continuing to look at individual providers and look at what we can do with individual providers and improving access, and we look at through our key lines of inquiry and on inspection around access, and we will continue to follow up concerns that are raised with us. So just looping back to what Chris said earlier in the meeting, if people have concerns about access, can they please get in touch with us through our Give Feedback on Care service, because we want to hear them and we will follow them up. Some of the issues that we can't look at relate to the commissioning arrangements and the how the access for dental services is looked at across a locality, and that's out of our scope at the moment, but we would be very keen if we were asked to look at that in more detail.
Yeah, we would indeed. Robert, were you wanting to come back? No, just okay, that's fine. But Stephen, your general point is well taken, and we do normally return to themes that we've been worried about, even where we don't have the ability ourselves to remedy whatever the situation was. We don't raise an issue and then just drop it. So we will definitely be back on this one, I think. So Chris, that was part one. Part two.
Part two, so collaboration amongst cancer services. So this is particularly looking at good practice in the way that services are working together to support people with cancer, and a number of themes of this good practice. I just want to highlight a couple of those themes. I'm conscious of time, but just highlight a couple of those themes. Firstly, we found that even during the pandemic, the engagement of local communities and the ability of services to work together to engage local communities and local sort of cancer alliances was critically important to how services operated and how they worked. We saw some systems where there was close liaison between community leaders, local faith groups, and services providing detection and treatment services, and they are critical in early detection and early support for people with cancer. We found another service where they were using patient advisory groups, creating videos highlighting the importance of things like lung checks through the pandemic to encourage attendance at appointments, and again targeting this work to people where there's a known high risk of people not taking up invitations to screening and treatment is important. There's also been a lot around innovation and collaboration using systems. So things like chemotherapy at home, which probably wouldn't have been a regular occurrence, has been much more prevalent during the pandemic. Virtual ward rounds where different organisations, professionals in different areas coming together virtually to talk about and plan how they keep people both safe and well cared for. And then the support for recovery as well, how services are beginning to think about their backlog, their diagnostic procedures, their surgery, collectively, not as individual organisations. And I say these reports are designed to show what is possible and what is working well. We have heard from system leaders and from people in both of these, and we want to encourage systems to think about what their recovery options could be using the information that's in this part of the report. And again, we'll come back later to talk about a wider view of provider collaborative reviews in cancer services. Thanks, Peter.
Thank you. Rosie.
Just following up from Stephen's question in the last regarding dental, in the provider collaboration review space, what we're doing is every time we've been into a system, we are feeding back all of our findings into that system, and we're asking for an action plan from that system based on the findings. So whilst this is an interim report, as Chris says, to share the best practice, because we've made that deliberate choice because we want to make sure that that good practice is out as quickly as possible, whilst we're waiting for the final report to be generated. We don't want the delay in people having that access to ideas and ways of improving the situation to benefit patient care. But we are very much working with the local systems to see how we can support them and share that learning and make sure that they are fully aware of the areas that they need to work on that we've identified.
Thanks. Ali.
Thank you. It was great to read about both of the areas in which we looked at, and cancer is a particularly interesting area because it's so vast and complex, spans so many different disciplines, specialties and ownerships, and also is an area where sometimes the changes that you make at the earliest stage may not be visible for some years to come too. Similarly, it's great to hear about the amount of organic development that's happened to make sure people can continue to access services at every level. Looking forward to the full report of the provider collaboration review, I think it would be very interesting to hear more, as you said, about the systems approach to cancer and how that's been useful in addressing it as a geographical area. But also, I think the fastest areas of potential development to address getting back to activity as quick as possible and what planning looks like, keeping in mind some of the comments that have been made earlier about the challenges that we will face in coming months. Thank you.
That's well made, Ali. And I think that there's something for me about the planning together, the adoption of technology and the way in which communities are involved in that we really need to make sure we can drive home in the final report. But yes, absolutely well made.
Great. Thank you, Chris, and the team behind the Insight report. Really useful couple of reports there. We're happy to move on. And that takes us to the Regulatory Governance Committee. A very good meeting last night. I'm sorry I couldn't quite stay to the end, had to leave to deal with something else, but it's a great meeting. Can you just give us the highlights, Mark, please?
Yeah, very happy to, Peter. And it was a good meeting, but which was informed by some very helpful papers from the executive. So thanks for the effort that went into that. Two substantive items on the agenda. First of all, we looked at the qualitative and quantitative insights from a review and evaluation of the TMA, the Transitional Monitoring App. Looking at the additional capability that has given us, some of the risks and issues and how those have been addressed, and the importance of robust evaluation and assurance. But we tied it into what would have been a separate discussion about future monitoring activity, and the main purpose of the discussion was to look forward to see how those learnings are influencing our forward thinking, our plans for use of data and intelligence, and our quality standards. We talked about consistency, but it was emphasized that there's no one size fits all approach to monitoring. And I think one of the really important parts of the discussion, which Stephen referenced earlier, was the vital role of inspectors continuing to exercise their professional judgment, and that's still going to be a vitally important, fundamental part of our approach going forwards. The second item was following on from a great review we had at the March meeting on adult social care. We heard from Ted and his team in relation to the Hospitals Directorate on learnings from the pandemic. We heard earlier in the meeting at how the Directorate had risen to the challenge, and we were pleased to see the sort of trail of increasing confidence with which the team had adapted monitoring and inspection activity to reflect the extraordinary restrictions that everyone was operating under. Again, the focus of the discussion was how those learnings are informing our future approach to regulation. One of the really terrific opportunities was to hear directly from some of our frontline colleagues. So we were joined by an inspector and a mental health reviewer who talked about their experience. And I think we were all pleased to hear that people had felt safe through the efforts of the organisation on provision of PPE, testing and risk assessment that had helped colleagues feel safe in the difficult circumstances in which they were operating, and also the commitment to communication, which of course Ian has led from the top with his twice weekly calls to all colleagues. We heard similar themes to the themes we'd heard from during the adult social care update. Pride from the front line in doing a really difficult job in enormously challenging circumstances. The importance of empathy, compassion, and care, which I think we know that many of our colleagues absolutely embody, and the importance of teamwork, being joined up internally and joined up with external stakeholders through this time. Next time we'll hear from Rosie and Primary Medical Services the same story. We looked at the forward planner and we looked at the risk register, particularly those risks that are relevant to our committee, and we were encouraged to see improvements in the residual risk scores. I think that was it.
Great, thank you. So anybody want to come in? If not, excellent. Thank you, Mark, very much. As I say, it was a great meeting, for at least for the part that I was able to be there for. Is there any other business for the board? Perfect. So that is the end of the board meeting. We do, though, have a couple of questions from the public, actually both from Robin Pike. So the first question is, how does CQC regulate telephone consultations in GP and hospital clinics? So I guess, Rosie, that's probably you and then Ted to answer that, if you would.
Yes, certainly. So we look at access through our work that we do on inspection, and part of that looks at the type of access people are getting and whether their needs are met through that access. So we look at whether people are being seen face to face through telephone consultations. We also make sure that all staff are trained in recognition of deteriorating patients, so that, for example, if someone is booked in for a telephone consultation but sounds like they're getting worse, that the receptionist or the person triaging that, taking that call is able to identify it. We also look at how people are signposted to the most appropriate level of access, and that how that's communicated out to people using services, and making sure that people do get that appropriate consultation. So I hope that
You were doing so well there, Rosie. Nearly made it to the end. Ted.
Well, Rosie did a great demonstration of the hazards of virtual technology there, which I thought was brilliantly timed. So in terms of hospital clinics, I suppose the first principle is exactly the same standards apply to telephone or virtual hospital clinics as would apply to a face-to-face clinic. So we don't have a different standard to regulate by, and we would apply exactly the same principles. In truth, if you speak to patients, a lot of the feedback we get about hospitals is about the unsatisfactory nature of clinics, long waits, delays, cancellations, car parking, which for people attending the hospital site is always a problem. And so I think we're very keen to encourage the appropriate use of virtual technology for clinics, and hospitals, of course, have been experimenting with that during the pandemic. However, that having been said, the standards of quality and safety will apply as ever.
Thanks, Ted. Fortunately, the second question is one for you, not for Rosie as well. So the second question from Robin is, what form do CQC visits to secure hospitals take when whistleblower information has been received? Well,
Robin, thank you very much for raising this. It's a very important issue. We apply exactly the same principles with the secure hospitals as we do with any other hospital. So whistleblowing information is processed in exactly the same way. We will assess the risk, and if necessary, we'll undertake inspections at short notice and unannounced as required. So the principles of regulating care in the secure hospitals are exactly the same as in any other hospital we regulate.
Thank you, Ted, and thank you, Robin, and thank you, board. We are finishing just 1 minute after the scheduled time, which is quite good. Unfortunately for the board, we have more work to do this afternoon, so we'll have some lunch and see you all at 13:40. Thank you very much indeed.
Thanks.